suicide, and their family members who are being discharged from a hospital or emergency department and going home after this incredibly life-altering event, not knowing what to do, where to go. Everybody was somewhat traumatized, not knowing what's next. And what Heidi had done is crafted this resource from the perspective of an attempt survivor, someone who had been there. And this resource had so much compassion and personal resonance and had her voice in it, this voice that spoke right to the people who were in the moment. And it was the kind of thing that you just don't really see in typically government-issued pamphlets. But you know, Eileen and I and others were saying, we've got to do something. We got to take this and you know, publish it through SAMHSA. And so we adapted it, and Journey Towards Health and Hope was created and just released like about a year ago, I think, maybe a year and a half ago, and it's now available through the Clearinghouse. And it was entirely inspired by your resource, what you put together, and again has this voice of suicide attempt survivors speaking to those who are going through it right now. And when I think about that and how moving that was for us to be a part of that together, I wonder what is it about? I mean, you had your suicidal experiences in the hospital and in patient units, emergency departments, healthcare systems. And as we talk about changing the healthcare systems, somewhere in there you said, this is missing. What in your experience as you were working in these environments and going through these environments as a client made you say, this voice has got to be here?
Well, first of all, thank you, John. And I think it started when I was in high school, and my brother almost attempted. My mother walked in and he was writing a suicide note. So he was hospitalized. And he came home, and when he came home, nothing was said or done, and it was so awkward. And I didn't know how to interact with him or what to say. I was afraid if I said something, was I going to make him kill himself? And so I avoided him because I didn't know what to do. And you know, fast forward like 30-some years, and I'm working in suicide prevention, and I assumed things were different. But I find out from people that they weren't. I found a woman came up to me and said, my husband attempted, and he was a smart man, and I figured, well, he got this out of his system. He was in the hospital. He came home. She said, nobody told me he was at an increased risk for suicide. Nobody gave me warning signs. Nobody gave me risk factors. Nobody said anything, and he later died by suicide. And I started to think, I think there's something that needs to be done about this. And I had it on the back burner, but it wasn't until I met a young woman. My group was holding a support group for attempt survivors, and she came in, and her mother wanted to come in with her, but we said it was a closed meeting. And this young woman was attending community college, and she said that her mother screened all her calls, wouldn't let her close her bedroom door, took her to class, picked her up from class, didn't give her a minute's alone. Well, she was waiting for her at the end of the meeting. And, you know, we told her, well, you know, she's just afraid she's gonna lose you, and she was, yeah, but at the end of the meeting, I was walking out with a friend, and we weren't saying anything, and I remember she smoked, and I didn't, and I'd quit for like 10 years, and I almost asked her for a cigarette, and she just, when we got to our car, she said, she's gonna attempt again, isn't she? And I said, I'm afraid so. I got in touch with her. I never heard back from her. I don't know what happened, but I knew from that moment on I had to do something. So I wrote a booklet for helping families after someone attempts suicide. And we distributed it to every hospital in Pennsylvania. But then I thought, you know, if I'm doing something for families, there's not really a whole lot out there for attempt survivors either. And when I would do my trainings and share my own experience and share what worked for me and what helped me, and how if I kind of looked at it as the voice of suicide and not who I was, and just, you know, just things that helped me and didn't, I found that it really resonated with people. People would come up to me and say thank you, or say that I can use that, or maybe this will help. So I went to one of our volunteers, Amy Cunningham, who was getting her postdoc from either Penn or Yale at the time. Talk about what a great gift to have a volunteer like that. And I said, do you want to do something about this? And she was like, oh, yes, I have people coming into my practice who want to ignore it. And yes, I'm in. So we wrote the booklet, and then we talked that we felt like it just wasn't getting the reach we wanted it to get. So we brought it to the Consumer Survivor Subcommittee. We were delighted that Samson was actually interested in it. So.
Yeah. Yeah, this is so important for so many reasons. It's one of those small things that has a huge impact, because it's not only do we know that attempt survivors have the highest rate of suicide of any group, so they're at the greatest risk, but as Richard was saying earlier, the point of discharge is the most risky period. So you send them home after this horrible thing, and they're afraid to talk about it. They don't know how to talk about it. You're not allowed to be sad anymore without them saying, "Are you suicidal?" It's just what's the instruction booklet? How do you deal with it? And you gave us one. Thank you.
Thank you.
Jessica Caudle. Jessica, you're committed to opening the public conversation about mental illness and suicide through sharing your own story. And you've just started doing that. But it started way back in 1990 when you lost your father to suicide, and you faced your own personal struggles, drug and alcohol addiction attempts, suicide attempts, and acceptance of your sexual identity in the years that followed. And you've been active as a participant and volunteer now with the American Foundation of Suicide Prevention since 2013. And how did that happen? All those years of struggling and dealing with this alone, well, you got a little pamphlet somewhere that said, here's this out of darkness community walk for suicide prevention in 2013, and you looked at that and you said, oh, I'm going to do this. I'm going to do this. And that simple gesture, I understand, forever changed your life. The words suicide prevention, as you say, took your breath away. And up until that moment, you felt like silence was the safest cloak for you in your misery. But now you hope to inspire others by stepping out of the shadows and talking about your story and helping people find their voices. You're now on the board of AFSP and that chapter in North Texas, while also working as a surgical technologist at a hospital in Fort Worth. But you're also studying psychology now, I understand, too. But more than anything, I love what you say when you say that I believe that I can make a difference one conversation at a time. So Jessica, could you talk with us a little bit about how telling your story, what that's meant for you, and I mean, this is still pretty new for you, so kind of coming out and talking about this after years of being in silence. And as you're talking about it, what kind of surprises, perhaps, have you had in talking about it? And in what ways do you think telling your story, have you seen, is helping others?
Thank you, John. And thank you all for the work that you do within your own lives for suicide prevention. As far as surprises, do you mean aside from sitting at the White House? That's a pretty big one. I am not a mental health professional yet. I'm simply a person that was duly impacted by suicide. I lost my dad when I was 7 years old. And I'm really glad, Kim, that you spoke about your children. Because even though I was so young, I do remember that experience and that event. And I remember so desperately wanting to talk about it and asking questions, but this was 1990. We've come a long way, and we still have a long ways to go. But I don't think my family had the language to explain it. I mean, everyone was impacted in their own way and struggling with it themselves. So it was something that that was kind of swept under the rug, and even though it stayed in the front of my mind constantly, there was no place to talk about it. And I think what I learned from that over the years was it was not okay to talk about difficult circumstances or pain, that you had to internalize it. And I did. I left home at 17 and ended up in Los Angeles. I grew up in a small town in Oklahoma, so it was completely different. But that is when I started facing my own struggles. I always knew that I was different, but it wasn't until I moved to Los Angeles that I experienced the LGBT community and realized that that's what it was. And that's something that I struggle with, was coming out to my family. And I wish, Amy, that I would have known about the Trevor Project and programs such as that. I think it would have been a tremendous help. So I think it was just a snowball effect of losing my dad, trying to figure out how to come out to my loved ones. I had a small group of friends in California that knew, and they were supportive. But I did attempt to end my life, and I'm grateful now that I'm here. It took me having my son to turn my life around, and he's 11 years old. He's amazing. But in 2013, a friend handed me a flyer for the Out of the Darkness walk through the American Foundation for Suicide Prevention. And up until, all those years, that was the first time that I saw it in writing. There was a place people went to talk about it. And I knew I had to go. I had no idea what to expect, but I got in my car. I registered, got in my car that morning and drove from Mansfield to Dallas. And the whole way I'm questioning myself, what am I doing? What am I going to do when I get there? I mean, are we going to talk about it? I had no idea what to expect, but I remember when I parked my car and I'm watching all these people walking over to the park, and lots of people wearing T-shirts with pictures of their lost loved ones, and I was blown away by the number of lives that had been impacted. And I ended up walking. Never dreamed in a million years that I would eventually become a part of this foundation. It was something that I figured I could do once a year that was personal to me, that would help me heal, which it has tremendously. But from there, I wore my community walk T-shirt to the community college where I was attending classes, and had 3 people in one class ask me about my T-shirt because it had suicide prevention on it. And it was in that moment that I realized that this was a much bigger issue than I ever dreamed it was, sadly. So I went home and started researching AFSP and saw where they do community walks in the fall, but they also do campus walks in the spring. So I went back to school and I asked those 3 students and I'm an introvert, this is completely out of my comfort zone, but I said, what do you guys think about bringing AFSP to TCC? Is this something that you'd be interested in doing? All 3 of them said absolutely. So we ended up going to student activities and organized our first walk the spring following my first walk. And we just hosted our 3rd one. And there were professors that came out and stood on the stage. One of them had lost his daughter. We had a counselor that came down that lost her dad. People came out of everywhere talking about it. So here I am talking about it, and I'm so grateful. Thank you.
Thank you, Jessica. We're so glad that you're talking about it and you're with us and one of the things I asked about was this, what's a surprise for you? And actually, what I was hearing in there somewhere was one of the surprises for you when you started talking about it was that you found out that you weren't alone.
Absolutely.
So, welcome.
Thank you.
So I'm aware of the time. We want to make sure that we give you all a chance to engage with our panel up here and ask some questions. David.
Well, I just want to say, first of all, it's so exciting, Bess, that you and the administration put together this central focus on suicide in healthcare is phenomenal. Thank you so much for that. But, and I'm a healthcare person. I love the focus on healthcare, and yet there's an aspect to this that is more than that. This is like the last stigma. There's a social movement here. It feels more like, if you think about Harvey Milk coming out with LGBT issues, Heidi Bryan and DeQuincy Lezine came out 20 years before it was easy to do, when the discrimination, frankly, and the stigma around this was so hard. And your efforts over these years, C.W. Tillman is in the back. I remember the watershed moment at AAS when we had a similar panel 5 years ago now. And I think looking back, we'll see this moment with all of you sharing your stories as a watershed moment as we begin to turn the corners.
I couldn't agree more. Anybody else? Yes. Oh. I promised you the first question. Shame on me.
Thank you so much, Beth, and thank you so much to the panel. This was so powerful. I am so honored actually to be here and to hear all of your different stories. My name is Debbie Orijo Manigat. I'm actually a family therapist, but now I feel like I don't know anything. And I'm here for my mom, who actually struggles with thoughts of suicide. So I have so much to share and empower and hopefully inspire her. And my question is, how do we, as clinicians, as community members, work with faith-based communities to help share this message and empower people who are laymen or pastors and clergy? Thank you.
Great question.
You know, I think it just really takes engagement. You know, there are often people take up, or congregations, faith-based communities will take this issue up because someone has been personally touched. And for example, I work with a congregation, a Reformed Jewish congregation in San Francisco that is really coming out and saying we need to be talking about this issue, we need to be talking about the difficult things. But that was because the rabbi lost her stepfather. But I can guarantee you, just like, you know, Jessica and everyone else has said, there's people in every faith-based community who've been touched by this issue. And it's just a matter of breaking down that fear and that stigma and that taboo and opening the door to these honest conversations. And, you know, one easy way to start is to have a speakers bureau or have a series, you know, just to open the door to conversation and see what comes of that. But I think it's just really about reaching out in your own community and doing what you can.
Feeling Blue actually started out as a dinner conversation with my minister. It started out as an outreach program of our church, and it was just me sharing my experience about losing my brother at the time. And then he felt comfortable sharing that he was bipolar. And so I was fortunate, and so we got together and we started the organization. But I agree with Leah. I think if you just approach and train and talk to them, that it's possible with any faith.
Yes, I'd like to address that too. Great question. I grew up in a religion that thought very badly about suicide and what happened to you afterwards, and so it was another thing that stigmatized my not being able to speak about it. But I think that, like we've heard today, in every aspect, conversation is definitely the best way, the only way I believe that we're going to get anywhere different than where we are. I think religion has been organizations that have been kept to themselves. But if we start the conversation, I think that's going to start changing the way we've seen it in the whole nation. So especially because if we're touched by it, we can bring it up. But even if we're not, even if we just have an opinion about it, if we start speaking and bringing up the subject, I think it'll grow.
It's interesting. When I was still a college student and had formed a student group around suicide prevention, one of our strongest advocates at the college was our college chaplain. And at one point, I was asked to go and speak with her congregation as well, and being able to have that partnership then with the faith community leader and somebody with lived experience both speaking at the same event was really powerful. We had a very close colleague of mine who has passed, Jim Clemens, who had done a lot of work around engaging faith communities around suicide prevention, and has written a book of kind of sermons about suicide and engaging faith communities in that. I'd have to put in a plug for the Action Alliance task force that did look at faith communities and engaging faith community resources. But I'd say that one of the main things is kind of gearing again towards that more positive perspective that it's about life promotion. It's not necessarily all about suicide prevention, it's about promoting life and promoting connections to that, having that general idea that people just being connected to each other. We saw the DOD video that it's a lot of times it's just about human connection, it's about caring about others. That's being one of the main messages that gets towards suicide prevention. So even if you're backing up away from, say, the focus on death and suicide, back towards just being able to be connected to people and promoting life.
It's a great question, and it doesn't surprise me that almost every member of our panel responded to it, primarily because there was a study that was done a few years back in New York where they asked people who were attempt survivors and had serious histories of suicidality, what keeps them alive when they're thinking about suicide. And the number one thing they listed was spirituality. And if one sees it in some ways as an existential crisis, spirituality has a huge role in suicide prevention. And we know there's plenty of evidence that does show that religiosity is a buffer. So how do we better engage them? And I think there are a number of circumstances where our community, the suicide prevention community, can do a better job of engaging the faith-based communities by giving them a role and reminding them how powerful they are already in some ways in suicide prevention. They can, we talk about attempt survivor support groups. A great place for that would be in churches where there are volunteers, and maybe crisis centers or others who work in the communities could also kind of help co-lead those. But we need to look at ways that we can partner and first acknowledge their important role in suicide prevention. And also they can acknowledge some of their limitations in dealing with mental health problems, and we can help each other.
Thank you so much. Not to the mic. I think we have time for one final question. Folks have them? Yes, sir.
Hi, everyone. Brian O'Donnell from Henry Ford Health System in Detroit. And I just want to thank you, first of all, for your being here today and sharing your story. I think what's particularly courageous about all of you being here is that you have migrated through and navigated through a very fragmented health system for a very long time. As many people are watching this from all over, and we're in the process of really trying to redesign our healthcare systems, I'd love to hear your perspectives on what you think are the key things, what are some of the things that you'd really like to see changed in our healthcare system.
I'll start. I would like to see using the same door. Not distinguishing between behavioral health and physical health. Just having using the same door and not having that. I just think until we start accepting the whole body and the brain is an organ like everything else, that we won't really make the headway towards stigma that I'd like.
That is a great question, and I wholeheartedly agree. We have got to start treating our brain health as importantly as we do our physical health. I work in surgery, and a lot of times I see patients come in and have broken bones, And I think of this every time. I know that they're going to go out of there once we complete the surgery and have months of rehabilitation. They're going to have physical therapy or work to get that strength back. It's no different than a broken heart or an ailment in the brain. We have to do the same thing. That's what I believe we have to bring together.
So thank you, great question. I talked a lot about one of my recommendations, which is to really infuse trauma-specific approaches throughout. And you can't hurt a person by behaving in a trauma-informed way. And also want to echo that we really need to look at the whole person. So mind, body, I also want to emphasize that. And then we need to get creative. I think, why can't people get support in their homes, like someone referred to earlier, after an attempt? Or if they would prefer to receive care in their home rather than an inpatient facility, or we need to, I think, be thinking outside of the box here and really be bringing the care to where people want to be instead of forcing them to go somewhere they might not want to be. I'm also a big fan of the suicide attempt survivor support groups. That we only have a tiny handful of those in this country, and we should have them everywhere. It should be as easy to find something like this as it is to find an AA meeting. So that's another one. And also my last one is crisis respite programs. We need so many more of these. These can prevent a lot of inpatient hospitalization. They can head off crisis before it turns into a suicidal crisis, and really, save people a lot of trauma and save the system a lot of money. So I think that's my whole range of recommendations. Thank you.
Speaking of trauma, there's a lot of things that happen within the healthcare system that are traumatic. So just recognizing the trauma that comes from a lot of what is sometimes called healthcare that is not really care. But one of the things that I'd say is kind of a somewhat traumatic experience for me, having moved a lot, is just going through the process, the intake process. Some of the times that I have had the worst day of my month, of my year, has been going through the intake process with my psychiatrist, my new psychiatrist, because it is an entire hour of, tell me what's wrong with your life. Tell me what's been wrong before, tell me what's wrong now, tell me about all the risks that you have, all the negative things that are happening in your life. It's a pretty depressing hour. So just that kind of trauma, being able to avoid that. Part of what would avoid that, as Dr. McKeon said, is having transitions, having more connections between healthcare systems, so that somebody doesn't have to go through those types of things over and over again when they're coming out of an intake, or if they're coming out of an inpatient setting, being able to just transition to an outpatient setting, having those types of conversations between the different types of sources or resources that they're having in the community. That kind of thing makes it more integrated, less fragmented, like you said, and would make a big difference in healthcare.
I would like to add, too, that, a lot of people we speak, especially in military families and veterans, is they very often don't seek behavioral health and mental health care until they're in crisis. And then it's hard to get them the appointment right when they need it, to get the treatment right away because they need assessments and all that. So I would love to see healthcare do a better job about having the conversation along the way about suicide, about thoughts of suicide, about mental health, and have it incorporated on a regular physicals and updates, and constantly talking about it, so it's not only talked about when you're in crisis, because then it's very difficult to respond with the needs that they have at that time.
Yes, and I'd like to say that I would like better training on every aspect, from, like I said, from the EMTs to anybody we deal with when we're suicidal. But besides the professional training, I think there's a lot of clinicians, a lot of professionals who have the book smarts, but to really emphasize the emotional or the connection part of it and the human part of it. I think that if we could integrate those two things, we're really going to save a lot of lives. And one last thing I wanted to mention, I also have, I forgot to before, is that postvention is amazing. The fact that I had never even heard that word, but I definitely never received that. In all the years I was in the mental health system, okay, I'll confess, 30 years, and never once did I get a call back. Somebody said today, I'm sorry, I think it was Richard, mentioned that if you're lucky you go home with a phone number. That was pretty much my story for 30 years. So I think that the fact that we brought it up today is going to make a big change too. Thanks.
So I think that closes our panel. I want to express my sincere appreciation to Bess and all the folks at the White House who put this together, and all of you who took time out of your busy schedules to come and join us today for this very important celebration of the work that suicide prevention has been done by this administration. If you think about it, really, during the Obama administration, the National Action Alliance of Suicide Prevention was established, and again, the movement of lived experience has flourished. This has been an extremely successful administration. Thank you for everything, and thank you all.
Okay, we clapped him on stage. We got to clap him off as well. Now, I know we are running just a little bit over time, but I can't say goodbye without having our two fabulous closing speakers close us out today. We are just so incredibly thrilled to have Dr. Christine Moutier, who is the Chief Medical Officer from the American Foundation for Suicide Prevention, as well as Dr. Carolyn Clancy, who is the Deputy Undersecretary for Health for Organizational Excellence at the U.S. Department of the VA. So I'll turn it over to Dr. Moutier.
Well, I just have such incredible respect for the wealth of knowledge, lived experience, and passion in the room. And talk about breaking down silos and making progress. I think the fact that this conversation has been happening in an ongoing way and at this national level is truly telling and gives me hope for the future. As the Chief Medical Officer of the American Foundation for Suicide Prevention, I really would love to thank President Obama, the First Lady, and Dr. Biden for their leadership and commitment to mental health and suicide prevention. And certainly a special shout out goes to Bess Evans for her tireless efforts in making healthcare, and particularly mental health care, more accessible to all Americans. So obviously we've been highlighting the fact that the rise in the U.S. rate of suicide, 24% over the last 15 years, has reached a national crisis, and we are now speaking out about that in an ongoing way. We've just heard from a panel that the mortality toll of suicide is actually just the tip of the iceberg, that there is a whole range and spectrum of suffering that goes on, and that within all of your workplaces, your churches, your neighborhoods, people with lived experience who have been touched by their own personal experience or lost to suicide are all among us. The number of individuals, families, schools, and workplaces who are impacted by suicide attempts, there are greater than 1 million suicide attempts in our nation each year. That boils down to 125 suicide attempts per hour, day in and day out. The suffering in silence must stop. We live in 2016. It's time that we show compassion for the 1 in 4 Americans who live with a mental health condition. It's time that we make mental health care affordable and accessible, and it's time to ensure that leaders in every sector, from corporate to government, but especially leaders in healthcare, understand the legitimacy and the pivotal nature of mental health. I want to share just a couple of examples of what I'm seeing as indicators of the changing landscape around mental health that actually give me a lot of hope. Recently, national leaders in academic medicine and medical education have come together to address the problem of physician wellness and physician suicide. A study just this week published by Dr. Gold found that 50% of women physicians report that they likely met criteria for a mental health condition as they looked back on their career, but had not sought treatment, mainly out of fear associated with stigma that still lingers in our culture about mental health and help seeking. When we as healthcare leaders and experts cannot even allow ourselves to be human, to be smart and seek the treatment that we need because it's not safe for us, or at least it doesn't feel safe, it's no wonder that our nation has seen conditions like depression going unaddressed and rising to become a leading cause of disability. It's time to act based on reason and based on science. And thankfully, leaders within the healthcare profession, including medicine, are taking that call to action seriously. So despite the hard work that is yet to be done, there is good news. Another indicator, a recent Harris poll that we and others put together, found that the American perceptions around mental health are changing, that greater than 90% of respondents view mental health as equally important and valid as their physical health. And actually over 90% said that if someone in their life were struggling with suicidal thoughts, they would want to help. Another indicator, you've heard about the Out of the Darkness suicide prevention community walks. Among run-walk events of that nature for awareness raising, the Out of the Darkness suicide prevention walks are the second fastest growing event in the nation. This tells you what the American public is interested in and is clamoring for attention to. And researchers continue to find the answers to what drives suicide and what works to prevent suicide, even interventions long before the suicidal crisis has emerged. So at the American Foundation for Suicide Prevention, we have set a bold goal to bend the rising tide in our national rate of suicide and to reduce the suicide rate to 20% by 2025. To accomplish this, and adding to all of the efforts that you've been hearing about that are phenomenally important, the American Foundation for Suicide Prevention launched Project 2025. Project 2025 is analyzing who we are losing, where we are losing them, and how we are losing them. Using a dynamic systems model, we've identified actions that will reduce the rate of suicide in the shortest amount of time and with the potential to save the most lives. So one example for Project 2025, we know, we've already heard about this quite a bit today, that a high percentage of those who die by suicide have been seen by a medical professional, either in primary care, behavioral health, or emergency departments within days to weeks of their death. These are people who've come in contact with the healthcare system, and their risk for suicide was either missed or they just didn't get the help that they so desperately needed. And just as we've heard so much about the amazing zero suicide framework, through higher standards of care, better training of healthcare professionals, and greater use of effective interventions in these settings, we can save many more lives. Another example from the project, 50% of those who die by suicide use a firearm to take their life. So Project 2025 is working with the gun-owning community, firearm retailers, instructors, shooting ranges, and local communities to promote suicide prevention education. And this is just the beginning. We know that we can't do this alone. You'll be hearing more about Project 2025 in the months and years ahead, and how an all-out effort from leaders across industry sectors and communities nationwide can work together to implement effective programs, policies, and interventions that will save the most lives in the shortest amount of time. Using evidence-based strategies, we can save lives and allow many more Americans who are struggling today to live full, healthier lives. So with that, I would like to next introduce our closing speaker, Dr. Carolyn Clancy. And she is a remarkable and accomplished physician in the field of quality and healthcare system leadership and strategy. She's trained as a general internist, and she, she has many accolades, including being a member of the National Academy of Medicine and the Institute of Medicine, but I would say probably equally important to the many accomplishments on her resume are what those who work with her and under her say about her. They tell me that she's an extraordinary leader and that she's a mentor to many. So I'd like to welcome Dr. Clancy, who is a fierce advocate for suicide prevention, especially in our veteran community.
Thank you so much. Well, Good afternoon, everyone. If I had to sum up this afternoon in one word, it would be wow. I came here with pretty high expectations, and they've all been exceeded. This has been an incredibly important forum. So I want to thank you, Christine, for a lovely introduction, and thanks to the American Foundation for Suicide Prevention and the Action Alliance and the White House on organizing this critically important forum, and of course, the amazing Bess Evans. As public sector co-chair of the Action Alliance, I've been very proud to be part of this unique partnership with the private sector in advancing a national strategy for suicide prevention. This is incredibly important to veterans because, as you heard people say in a variety of different ways, 20 veterans a day take their life. 6 of them get their health care from us. The rest get health care elsewhere. Even those who get health care in our system often are getting health care elsewhere. And by the way, there's a whole lot of real life that takes place between health care encounters. So our goal is all of those veterans to be able to prevent those needless deaths. And we can't do that without partners. And just to be reminded today about the amazing partners who are out there and to be part of this alliance is just very, very inspiring and the source of a lot of hope for me. As a Deputy Undersecretary for Health, I'm honored to work with Dr. Shulkin and a number of really terrific clinicians, researchers, social workers, and other VA staff who work every day to help prevent suicide. And it's personal for me. I lost my mother, and we lost a very close friend who took his own life a few years ago when he was home on leave. So this is something that has affected so many of us. So I have to agree with you, Bess. Panel number 2 was the best. Just absolutely. It's an incredible gift to share that lived expertise. So thank you. I learned this a little over a year ago when I asked the parents of a veteran who had taken his own life, Gene and Howard Summers, who've been extraordinarily generous and energetic in their efforts to help us do a better job preventing suicide and, frankly, to make VA health care be all that it can be. I asked them to join me in a webinar, and it was a little bit more like a talk show on TV, although I was not quite up to the part of being that kind of hostess, but it was something that you could watch live or later on demand. And what blew me away about this was clinicians tuned in, and people who assist clinicians, but far more employees who are several steps removed from the direct provision of care, either emailed in their questions then or later because they had family members or because they'd heard we were trying to make efforts to see veterans that day with an urgent mental health problem if at all possible. And you heard Dr. Shulkin talk about that. And they weren't really sure, did that mean all veterans or was that only young veterans or people who'd served since 9/11 and so forth? And it made me more aware than ever why Henry Ford system has been so successful, because it is a team sport. Every single person who's part of that healthcare experience has to be part of it. You also heard Dr. Shulkin refer to this for veterans as a crisis, and it reminded me, and the discussion this afternoon reminded me about the old adage, right, that there's a symbol for crisis that means both danger and opportunity. And hearing from everyone today reminded me very acutely of the opportunities. I want to touch very briefly on some of the research that's going on in our system that gives me a great deal of hope, and then just end with 3 major points I'll take away from today. So many of you may not be aware the VA does a lot of research and has been for about 90 years. And focus on post-traumatic stress disorder, traumatic brain injury, spinal cord injury, and chronic illnesses that are unique to or more common in veterans is a very, very big part of that portfolio, which also includes a strong focus on substance abuse and suicide prevention. So we have a number of centers of excellence, and just by way of a few examples, a center of excellence for suicide prevention based in Canandaigua, New York, which was the home and hub of the first crisis line, works towards reducing veteran suicides primarily by studying and applying public health approaches. Okay, so this is outside of healthcare. Another center in Denver The researchers are focusing on how do we translate these promising research findings into improving everyday practice as rapidly as possible. And another center in Little Rock focuses on research to improve access to and engagement in evidence-based mental health and substance use care. We also work very closely with the Military Suicide Research Consortium. Very importantly, we have a very large cooperative study going on now that we were thrilled that President Obama mentioned at the American Legion Convention a couple of years ago, focusing on 1,800 veterans with bipolar disorder or depression who have survived a suicide attempt to see if lithium can actually help prevent suicide in those at increased risk. Obviously, listening to the second panel, lithium alone won't do it, but is that a very key part of the recovery and ultimate survival process? The last thing I want to mention to you is this year we have been focused very strongly on diffusing best practices. So we're asking the people with the most knowledge, that is to say the people who are providing care, to submit what they consider best practices, and we have a whole contest around this that involves a Shark Tank-like event. And so far we've received input from about 70 facilities out of about 150 and about 3,000 ongoing implementations. So related to suicide prevention, we've seen a partnership with local law enforcement in rural Indiana to help police officers better understand veterans with post-traumatic stress and suicidality and help them understand VA resources and so that they can help get the veterans into care. That has been hugely, hugely important. Another effort in Atlanta is providing greater clarity and definition for mental health nurses in outpatient care so that we can improve employee engagement and veteran outcomes. And in Miami, VA staff have just completed a pilot project for a triage tool that addresses the current gap in protocol interventions specific to acute mental health care issues. So this is just a small teaser of very exciting work in progress. I think my colleague, Dr. Ira Katz, was here earlier and may have left. We're also now going to be testing some approaches based on big data, identifying those at higher risk of suicide to see if that will actually help us intervene earlier. Doing this in a way that's sensitive, that doesn't put a big label on veterans and doesn't in any way increase stigma, which would be exactly where we don't want to be, is going to be a vital part of this. So as a clinician and a researcher and frankly a survivor, I'm greatly encouraged by the research, innovation, and best practices that we're seeing at VA. The progress we're making will help veterans and all Americans at risk for suicide. And Dr. Franklin, I was just inspired by that video. And I can say, as a family member and close friend of two people who took their lives, I know that there's a lot that we can all do, and being there is a very big part of it. Number of people this afternoon mentioned reducing stigma. I'm going to tell you, based on my own experience, I think I would qualify for an advanced degree in the many ways you cannot talk about the issue. And if you ask, by the way, you won't be planting the idea in someone's head. I can almost guarantee they've thought about it before and may be immensely relieved to actually have someone ask. But being there is just so important. So if there's three messages I will take away from this afternoon, one is the very important messages we heard from those with lived expertise and what a gift it is that you can share it. So thank you from the bottom of my heart. A second, and this is one we live with every day, this is a team sport in the broadest definition of the word. We need as many partners as possible, and having an opportunity to share what we're learning like this is really, really incredible. And the third, that I think we all know but probably don't say enough, but we heard this a number of times, there's a very, very close relationship between preventing suicide and the response to multiple kinds of crises. which might be the death of a spouse, might be loss of a job, could be discharge from service and where is my life and I don't know how to be anymore. It could be many, many things. And I think the more that we can bring those things together, we will make our partnerships even more powerful. So again, thank you all. I want to congratulate the organizers and again, thank particularly panel number 2. That was really, really special. Thank you.
Thank you to Dr. Clancy, to Dr. Moutier, and to all of you. I know that our program ran a little longer because we just had too much to pack into the time that we had, and I think we could spend weeks in this room, although maybe not in this windowless, non-social media conducive room, but in some room talking about all of the work we have to do moving forward. And I just want to remind folks that this is the beginning of the conversation, or even the middle of the conversation. It's not the end. And for better or worse, you'll now get lots of emails from me. And I expect to get lots back because we have 4 months left to run through the tape here for this administration, but a lifetime of work to do altogether. So thank you so much for coming today. Dr. Franklin.